Hi, it's Jennifer Gibson with Axxess. I'm a registered nurse, a certified coder, and I'm certified OASIS specialist as well. I'm glad that you could join us again for our webinar today. We are still navigating the highway of ICD-10-CM. We are on part 5, which is wound care coding, and today we're going to learn all about wound care coding in ICD-10. Our objectives today are to understand why proper coding is important, to learn who is responsible for applying and assigning diagnosis codes. We're going to study the guidance for coding common wound types in ICD-10, and then we're going to apply that knowledge to common home health wound scenarios. So we're going to talk just briefly about the guidance regarding who does the diagnosis coding and who should be responsible for sequencing those diagnoses. If you want more information on these first few slides, you're welcome to go back into the library and find part 1 of the Navigating ICD-10 series, and that will talk a lot about the regulatory matters that have to do with coding, as well as cover any other questions that you might have, and then it goes over the basic guidelines and conventions. So again, according to our OASIS C1 guidance manual, who and what diagnosis should I use? Your primary home health diagnosis when you're looking at the OASIS, that should be the chief reason the patient is receiving home care. That primary diagnosis is usually in the first position, and that diagnosis is most related to the current home health plan of care, and it's only a current diagnosis that can be used in the primary position, and that also applies for secondary diagnoses as well. For example, if the patient had cholelithiasis, they went into the hospital and had their gallbladder removed, they no longer have cholelithiasis, so we don't code that in home care. Instead, we would code aftercare of the GI system. Now, the secondary home health diagnoses are those comorbid conditions that exist at the time of assessment, and they are also actively addressed in the plan of care, or they have the potential to affect the responsiveness to treatment and rehabilitation prognosis. So if either of those apply to this diagnosis, you would go ahead and also code that as a secondary diagnosis. Now, the selection of the primary and secondary diagnosis must be made by the assessing clinician. Now, the clinician who goes out to assess the patient is expected by CMS and by your professional license to understand that patient's overall medical condition and the care needs before you select the diagnosis. Now, when we're talking about a diagnosis here, we mean literally the name of the disease. We are not diagnosticians. Those names of diseases should be coming from your physician, and you should have the knowledge, having read through the documentation that you receive from your referral source or from the physician or facility's records, you should know what the primary reason that you're in the home for is. And once you know that, you can then sequence and apply the diagnosis names. If you don't know the diagnosis code itself, the numbers and letters that make up the ICD-10 code, you should have policies in your agency which let you know that you can write the disease down, the name of it, and sequence it, and then someone else can come in and add the code itself. Now, those diagnoses are based on assessment findings. And by diagnoses, I don't mean that we're literally adding diagnoses. I'm not going in and seeing a patient and saying, they look depressed, and their PHQ-2 triggers out that they have some depression risk, so I'm going to go ahead and put depression down. Everything that we code has to be supported in the medical records from the physician. So when I say diagnoses, I mean the sequencing and selection of those diagnoses. They're based on the assessment findings, your medical record, and input from the physician. So again, according to the OASIS C1 guidance manual, the assessing clinician should be the person to record the primary and secondary diagnoses in the OASIS items M1021 and M1023. Now, the coder can add the diagnosis code itself after the assessing clinician has determined the primary and secondary diagnoses. Okay, let's move on. Getting the right diagnosis. Now, when you're trying to select the correct diagnosis code or the correct diagnosis, we need to consider the following criteria. That code must be compliant with coding guidelines. We are to code only unresolved diagnoses. We are to code only the relevant medical diagnoses. All the diagnoses we choose should be supported by the patient's medical record documentation. We need to ensure that we are complying with sequencing requirements, that etiology and manifestation codes, for example, are sequenced and reported properly. And then we're told we should avoid nonspecific or ambiguous codes or the coding of symptoms when possible. The criteria for selecting a primary diagnosis is as follows. Number 1, it should be related to the current plan of care. And if more than one diagnosis is being treated, we need to look at the diagnosis that represents the most acute condition, which requires the most services, and is the chief reason for home health and requires the most intensive skilled services. Those are the criteria for the primary diagnosis. What's the main reason we're there? And then we also know that it shouldn't be a Z code unless absolutely necessary. And sometimes we use M1025B in home care. And we know that that primary diagnosis is not a Z code unless absolutely necessary. Although sometimes we still use M1025B for home health, we don't use it as much as we used to use M1024B in ICD-9 version of the OASIS. Because the ICD-10 codes are so much more specific, we don't have a lot of aftercare codes that replace regular diagnoses. Now, when we're selecting a secondary diagnosis, we need to consider the following criteria. So all of your secondary diagnoses should be diagnoses that didn't meet the criteria for being in the primary diagnosis spot. The diagnoses used as secondary diagnoses are addressed in the plan of care, and they affect the patient's responsiveness to treatment and rehab. And then we list those in order to best reflect the seriousness of the patient's condition and to justify the disciplines and services provided. So, for example, if you're in the home for pressure ulcer wound care, but the patient also has diabetes, and they have CHF, and they have COPD, and they have hypothyroidism, let's say, you're going to sequence all those comorbid conditions in a secondary diagnosis position, but you're going to move them around according to acuity unless there's a coding rule that tells you you have to code them in a different sequence, okay? Basics of coding. The very, very basics that we need to remember is to always start in your code book. Always start in your alphabetical index first. And the dash at the end of an entry in the alphabetic index means that additional characters are needed. And then you're going to check for guidance. And if you notice C or C also, take that as a command and not as a suggestion, because there's often additional information that will help you see if you're at the right code or not when you flip over to the entry listed after C or C also. Once you have looked in the alphabetic index, you're going to double check the code that you find in your tabular index. And once you're in the tabular index, which is the second part of your code book, that's where the diagnoses are laid out in different chapters according to body systems, you're going to look for guidance at the chapter level, at the chapter block level, at the 3-character category level, and then the final code level. There may be conventions or additional instruction at that level as well. So let's get right into our wound care coding today. Let's first think about the foundations of wound coding. I want you to look at the 2 wounds that are here on the screen. Can you tell me, just from looking at these wounds, what the origin of the wound is? I'm just going to let you think about that for a moment. Let's look at the wound on the left, on the top of the foot. You know, when you look at that, you start to realize, that could be from a number of problems. It could be an abrasion. It could be a burn. It could be some kind of an ulcer. It could be due to a spider bite. I mean, there's just a myriad of things that could have caused this wound. It could have been an accident of some sort. The wound on the right, when you look at that wound, especially if you have some experience, you might be able to know that that's a pressure wound, Or it could have been a chemical burn. I mean, it could be any number of things. The point I'm making is that we can't tell from just looking at a wound what happened to cause the wound. What is the origin? And I make that point to tell you this. One of the basic foundations of wound coding is to remember that the physician or the provider must state the origin of the wound. And often in home care, the coordination or query is needed in order to find that information, because quite often you'll see that the patient has a wound, but you won't be able to find necessarily in documentation what the origin of that wound is. Remember, documentation in the record must support the diagnosis that you choose. So we can't just willy-nilly look at things like, oh, the patient's diabetic and they have a wound on their toe, so that's a diabetic ulcer of the toe. No, we must have the origin of the wound stated by the physician or the provider. And then once we know that it's a pressure ulcer or a non-pressure ulcer, our clinical assessment will guide the severity of that wound. Another no-no that I want you to realize in coding for home care is that we use the word open wound quite often. I see that all the time, and there are codes for open wound, but what I want you to know is that open wound does not equate an unhealed wound. An open wound does not have a default definition. So again, we want to stay away from open wound. Open wound usually means this is a trauma wound of some sort. When you follow the codes for traumatic wounds, they usually go to a description of an open wound in the back. And that generally tends to mean that it's a trauma wound of some sort. But we use open wound for all kinds of things in home care. If it's a surgical wound that's healing slowly, sometimes you'll see that documented as open wound. Again, don't get in the habit of using that word. As a matter of fact, you should never or seldom ever document in your charting that it's an open wound. You should be documenting the origin of that wound stated from the physician records. And once we have that, again, the documentation by the clinician is adequate, however, to code the severity and the location of a pressure ulcer or the depth of a non-pressure ulcer. Now, another no-no, according to the OASIS C1 guidance manual, the selection of primary and secondary diagnosis must be made by the assessing clinician. Again, the clinician is expected to understand that patient's overall medical condition and care needs before selecting the diagnoses. And those diagnoses are based on assessment findings, your medical record, and input from the physician. All right, our next subpart that we will talk about today is coding of pressure ulcers. Now, pressure ulcers and ulcers in general are found in the ICD-10 code set under chapter block L80 to L99. Pressure ulcers are located at the 3-character category L89, whereas non-pressure ulcers are found at L97. And you see in our little diagram here some common locations of pressure ulcers. So again, you're going to assign as many codes as are needed to identify all the pressure ulcers. So in ICD-10, if you have multiple pressure ulcers in multiple sites, you will have the flexibility of having multiple codes that include the site and the stage. We won't be coding those like we did in ICD-9, okay? Now I want you to look over in your code book at the top of the L89 chapter block. Look at that guidance, and you're going to see it says code first any underlying gangrene. So if you have a pressure wound or any other kind of wound for that matter, but pressure wound especially, the guidance tells you if this pressure wound has gangrene, you're going to first code gangrene, then you're going to code the pressure ulcer. Now I want you to also notice at L89, the 6th digit of these codes, or the 6th character, tells the stage of the pressure ulcer. For example, 0 is unstageable, 1 is stage 1, 2 is stage 2, 3 is stage 3, 4 is stage 4, and 9 is unknown. Now, when on earth would you code unknown as the stage of a pressure ulcer? We have the ability as clinicians to assess, and we can use our assessment to say what stage this is. So when would we ever put unknown? The only time I can ever think of that would be if the patient, for example, had an unremovable dressing. And the only time I can think of that would be if, for example, they had a fracture and they went to the orthopedist and they removed the cast, noted that there was a stage 1 or 2 pressure ulcer underneath the cast, and for whatever reason went ahead and recasted that patient. I can't imagine them doing that for reason of malpractice and for medical risk. But if they did that and sent you documentation that there's a pressure wound beneath that cast and you can't assess the depth of it, in that case you might have a 9 unknown for the depth. Otherwise, I can't ever imagine a reason you would do that. So don't get in that habit either, okay? No additional code is needed, as these codes are combo codes that include the site and the stage. Now, on pressure wound coding, again, you want to make sure you check the documentation from your facility or the physician when you stage the wound. If you don't have any clinical documentation found, then you're going to use the clinical assessment at the time of that visit to guide the staging. However, the reason I say look back at your documentation, we know from the National Pressure Ulcer Panel, Advisory Panel, and from our OASIS training that once a pressure wound is at a worse stage, it's always that stage. So for example, if it starts out as a 2 and then it advances to a stage 4, it will always be a stage 4. So as we said, it will always be a stage 4. The only time that will change would be never, right? So the stage 4 pressure wound, even if it looks like a stage 3 as it gets better, we don't downcode or downstage those wounds as they heal. Now, the opposite is true, however. If it starts out as a 2, you will actually progress that to a stage 4 as it gets worse, but you don't downstage as the wound heals, okay? Now, even when it advances in stage during care, you're going to assign the code for the highest stage reported for that site consistently throughout the record from then on. So let's say that the patient was in a nursing facility before they came home to home care, and in the nursing facility documentation, it says the patient has a stage 3 pressure wound on the sacrum. And you go out and assess the patient on start of care, and sure enough, it looks like a stage 3. You're going to keep that as your staging. If at research time you look at it and it looks like the patient now has a stage 4 at research, you would go ahead and change it from a 3 to a 4 at that time. At the next research period, now it looks like a stage 2. It's gotten a lot better. We don't go and change it from a 4 to a 2. It will always be a 4 from then on. The only difference will be that now that it's a 4 and it's getting better, we will talk about the depth is decreasing and that it's granulating well. It's gone from maybe a 2.5 centimeter deep stage 4 to a 2.0 centimeter deep stage 4. And that's how you'll document that. All right, so pressure ulcers that have been surgically debrided are still pressure ulcers. They're not surgical wounds. Sometimes you'll get a pressure ulcer, you know the origin of it, but it has slough or eschar, and either our physical therapist or the physician or the wound center surgically debrides that eschar or slough. It's still a pressure ulcer. It's not a surgical wound. It's just now a clean, hopefully, pressure wound. A muscle flap treatment for pressure ulcers do become a surgical site because of the in-depth procedure that you have going on, and at that point you can no longer see the base of the wound and code it as a pressure wound. It is now a surgical site. However, skin graft placement of pressure wounds does not change the pressure ulcer to a surgical wound because it's very superficial, okay? So skin graft placement is still going to be a pressure wound. All right, we've talked about pressure. Now let's talk a little bit about non-pressure ulcers, and there are many kinds of non-pressure ulcers. When you code a non-pressure ulcer, your clinician must document the degree of exposure on the non-pressure ulcers. So you have to know some basic anatomy and physiology to know what you're looking at. If your clinicians don't know this information, you might want to have a WOCN, wound ostomy continence nurse, come in and give a class, because you'll need to identify whether the non-pressure ulcer is down to just skin breakdown or if there's a fat layer exposed, if you notice muscle necrosis or bone necrosis. You're also going to notice for non-pressure ulcers, there's guidance to code first the underlying condition, such as arteriosclerosis, diabetic ulcers, varicose ulcers, atherosclerosis, or gangrene. Now, the sixth character of these codes at L97, which are your non-pressure ulcers, that will be what shows the severity. So in order to choose the right code, you're going to need the documentation. The sixth character is a 1. That means it's limited to the breakdown of the skin. If the sixth character assigned is a 2, that means the fat layer is exposed. 3 means necrosis of muscle, 4 means necrosis of bone, and 9 means unspecified. All right, let's talk about diabetic ulcers for a moment. When you're looking at the diabetic ulcer coding, it tells you in the diabetic ulcer code category to code first diabetes type and manifestation, then you're going to code a non-pressure ulcer. You need to make sure the documentation in the medical record from the physician or the facility backs up your diabetic ulcer diagnosis. There is no diabetic osteomyelitis in ICD-10. So in that case, if the patient has documentation that says that they're having a wound with diabetic osteomyelitis, that means you need to code diabetes with other specified manifestation first, and then you're going to code osteomyelitis right behind it. Example, the diabetes codes would come from E08 to E13 depending on what type of diabetes the patient has. And then you're going to use a manifestation with foot ulcer. And then you're going to have to use an additional code from L97 to indicate the location of the foot ulcer. Let's do an example here. E11.621 is type 2 diabetes mellitus with foot ulcer. You would follow that by L97.4, and then in that where the dash is, it would be the depth of the non-pressure ulcer. And then L97.5, then you're going to have the depth from the clinician's assessment. The next category we're going to talk about is cellulitis. In cellulitis, we know that that's a spreading infection of the tissue of the skin. We're going to check for sequencing guidance at the 3-character category level, and then we know not to code cellulitis without physician diagnostic statement saying that it's actually cellulitis. Now, the codes at L02 are abscesses, and they do not include cellulitis. Now, in ICD-9, those two were combined into one code category, but that's not the case in ICD-10. L03 category level includes cellulitis, whereas L02 category is your abscesses, your furuncle, and carbuncles. So again, L02 category is abscesses, furuncles, and carbuncles, and there's guidance at that category level that says use additional code to identify the organism causing the abscess and so on. Now, when you're coding an organism that is the cause of another problem, those codes will always come from B95, B96, or B97. And the guidance here that says use additional code to identify organism, they're always good to go ahead and tell you what that code might be. All right, so sometimes an ostomy is going to cause cellulitis, or there'll be cellulitis around the ostomy. When that's the case, you're going to need to code the ostomy complication as well. So for example, if you have documentation from the provider saying that the patient has an infected colostomy with cellulitis, you're going to code K94.02, the colostomy infection. There's guidance there that says also to use additional code to identify the type of infection, such as cellulitis. So in this case, you'd have K94.02 for the colostomy infection, followed by L03.311, cellulitis of abdominal wall. And if they knew the organism causing the infection in cellulitis, like staph, you would have a third code right after that that would say Staphylococcus whatever as cause of infection, and that would be a B95, B96, or B97 code. All right, let's talk about other skin infections in general. You will find that it will tell you things like use additional codes to identify infectious agents, some terms you need to know when you're coding skin infection guidance. Abscess, that's a localized collection of pus in any body part that results from invasion of a pyogenic bacterium or other pathogen. A carbuncle is a painful, deep abscess of the skin that involves multiple hair follicles, and it's formed by the merger of two or more boils, which are actually called furuncles, and they drain through multiple follicular openings. Ew, I'm glad I'm not a dermatologist, right? Again, it says to use additional codes to identify the infectious agents when you're looking at these different problems. More terms to know are furuncle. A furuncle is a tender dome-shaped skin lesion. It typically is caused by infection around a hair follicle with Staphylococcus aureus. Old people used to call these boils, or non-medical people may still call them boils. A cutaneous abscess is a localized infection of the skin, whereas the cellulitis we talked about a minute ago, that is the spreading bacterial infection of the skin and subcutaneous tissue, and it's usually caused by streptococcal or staphylococcal infections in adults. Your skin infection guidelines, again, terms to know, things like lymphangitis is infection of the lymph vessels or channels due to infection at a distal site to the channel. For example, you may have an injury on the hand, and then with lymphangitis, you'd have a red streak running all the way up the arm in the lymphatic vessel or channel. Pyoderma is a skin infection with thick yellow or green opaque liquid. And then pemphigus is a watery blisters that form on the skin. Now, skin disorders can also be caused from drugs, sometimes a drug reaction. And we have guidance here that tells us for drug-induced skin disorders like pemphigus or bullosa or dermatitis, we are told to use an additional code for the adverse effect and then to identify the drug. So the 5th digit character 5 would be used for adverse effect codes. Now, if you look at chapter block L55 through L59, you're going to need to pay attention to conventions at the code level for use additional code or code first instructions. For example, when you look at L57, skin changes due to chronic exposure to non-ionizing radiation, it tells you use additional code to identify the source of the ultraviolet radiation. Notice it's a convention. Although the guidance will tell you that no external cause code is needed, this convention tells you to identify the source of the ultraviolet radiation, and conventions in the chapter level trump general guidance in the front of the book, okay? So in this case, at the L57 category, we would want to know if this is ultraviolet radiation from, say, a tanning bed or some other kind of ultraviolet radiation. Okay, let's talk a little bit about surgical wounds. Now, when you're talking about surgical wounds, depending on how quickly after surgery that you get the patient, you may not really know if you're doing wound care because there's a complication or if it's just routine aftercare. So you may have to find out if it's not in your documentation. You may need to query the physician. But the first thing you need to know is if the reason for care is due to a complication of surgery or is it just routine aftercare, because you're going to code very differently depending on what's going on. Routine aftercare is coded from Chapter 21. These are Z codes, and some of these codes are straightforward and some are not. For example, Z47.1 is aftercare following joint replacement surgery. This is just a routine knee replacement. Everything is exactly like it should be. There's no dehiscence. There's no infection. It's just still steri-stripped and oozing a little bit perhaps and swollen and all of that, but it's progressing as it normally would. That would be the Z47 aftercare code. Z47.3 is aftercare following explantation of joint prosthesis. Z48.2, aftercare following an organ transplant. Z48.3 is aftercare following surgery for neoplasm. Z48.81 is surgical aftercare following surgery on specified body systems. Now, routine aftercare, again, coded from Chapter 21, the Z codes. Some other codes are a little more misleading. For example, the codes that we're about to look at below are intended to be used for aftercare, although they don't necessarily say aftercare. They look kind of weird. But Z40.01, for example, encounter for prophylactic removal of breast. This would be routine aftercare for surgery for someone who has maybe the gene for breast cancer, and they go ahead and have a mastectomy before any cancer is detected. They just go ahead and remove the breast to decrease their risk, and everything's running smoothly and as it should. There are no complications of surgery. That would be a Z40.01 code. Z42.1 is encounter for breast reconstruction following mastectomy. Once they've healed from the mastectomy, they go back later and have breast augmentation. This would be the correct code for that. Now, make sure you consult your code book for tips and a full list of codes that are appropriate for aftercare. Again, remember, is the reason for care a complication or is it routine aftercare? Remember, complications are coded somewhere else. They're usually found in the chapter laid out by body system. Toward the end, you're going to find complications. Complications are things such as infections, dehiscence, abscesses, hematoma, or pain. Now, intraoperative and post-procedural complication codes should only be used when there is a clear physician documentation that relates the condition to a complication or a procedure. Now, one other thing we want to talk about surgical wounds, whether or not you should code the wound care itself. At the Z48.0 category, you have two codes. Z48.00 is encounter for change or removal of non-surgical dressing, or Z48.01, which is encounter for change or removal of surgical wound dressing. Now, you don't use these two codes as primary diagnoses. Don't get confused about what is your primary reason for home care. Oh, we're there to change dressing and put that in the first place. Dressing change is not the only reason you're there. You're there to assess the wound. You're there to observe it and make sure it heals properly. So you're going to code the wound itself or the aftercare and not the dressing change. Another thing to know about these two dressing change codes is that you're not going to use these dressing change codes with the complication code. You would only use these for aftercare codes. So if you have a complication like an abscess of a wound or an abscess in surgical site, you would not then put Z48.01 as well. Dressing change, surgical dressing. You don't need to use that with any kind of complication code. Now, another thing that people often get mixed up has to do with amputations. Sometimes you will see wrong coding in charts where they've chosen the wrong amputation code, or they end up looking for and getting the traumatic amputation rather than the surgical amputation. Remember, the majority of amputations result from an underlying condition and not trauma. Not many people get run over by a train and get their leg amputated like in Fried Green Tomatoes at the Whistle Stop Cafe in that movie, if you've seen that. A lot of amputations happen from gangrene and circulatory issues. So complications of amputations like dehiscence or infections or necrosis and neuromas, those are coded from Chapter 19. And to find those, you're going to see complication, amputation stump in your alphabetic index to find those codes. Let's talk about traumatic wounds next. Traumatic wounds are usually due to or are due to injuries of some kind. Now you're going to code each injury separately unless a combination code is provided in the ICD-10 code set. When you're coding all these different injuries, you want to code the most serious injury first. However, when a primary injury results in damage to nerves or blood vessels, you're going to sequence that primary injury first, and then you're going to follow that by the codes for the subsequent injury to the nerves or vessels. All right, now that always brings us to skin tears, because we think, it happens when they fall or they bump their arm. That's a trauma. So we're going to code traumatic wound. Well, there's some guidance that came out about this. Coding of skin tears, you're actually looking for superficial injury. It's not an open wound. It's not a trauma wound, even though it might be caused from a fall or a bump or an injury. So you're going to look for superficial injury, forearm, for example, to code that. All right, your burns and corrosions, those ICD-10 classifications, it separates burns and corrosions. It calls them two different things. Remember, your thermal burn is due to a heat source, excluding the sun. You don't code sunburns normally, and they can result from electricity or radiation. However, corrosions are due to chemicals, but the guidelines are the same for burns and corrosions, and that guidance is as follows. You should sequence the worst burn first. In other words, the burn of the highest degree, third-degree burns, then second degree, then first, when you have multiple burns being cared for. So again, burns of the same local site but different degrees should be sequenced with the highest degree first and then so on. Any burn that's non-healing is coded as an acute burn, no matter how old it is, and necrosis of a burn is coded as a non-healing burn. Late effects of burns should be coded with the 7th character S for sequelae. When it's appropriate, you might have a current burn and a sequelae of a burn on the same record. For example, let's say the patient had second and third degree burns on the back of the hand and the wrist and the forearm. So you might have had a second degree burn on the hand that has healed, and now you have some scarring and contracture, and then you have a third degree burn on the wrist and lower forearm that's still open and draining a little bit. That would be an acute burn. So you could have a sequelae of the burn on the hand and an acute burn on the forearm and wrist at the same time. Burns and corrosions, of course, heal at different times. So now we've gone over some guidance with the wounds. Let's hit the driving track and do a little practice. You ready? Let's go over some scenarios. Practice scenario number 1. In this case, your 82-year-old female patient fell and has a skin tear or partial thickness wound to her right forearm. You contact the physician, you make a PRN visit, and you notice there's a 4 by 2.5 by 0.3 centimeter L-shaped wound with a non-adherent skin flap that was rolled under. Per new orders, you cleanse with normal saline. Then you gently relocate the skin flap onto the wound base using a sterile cotton-tipped applicator. Then you apply Xeroform dressings, foam dressing, and cover with rolled gauze. Patient also has hypertension with stage 3 chronic kidney disease and chronic obstructive asthma. So why are we there in the home? Your first item, if this is at a recert, is S50.911A, unspecified superficial injury, right forearm initial encounter. This is one of those cases where the initial encounter happened from the home care agency. We call the doctor, we get new orders. This is the first time it's being treated. It is an initial encounter. Your second diagnosis, I-12.9, hypertensive chronic kidney disease with stage 1 through stage 4 chronic kidney disease. M1023C is N18.3, chronic kidney disease stage 3. There's guidance at I-12.9 that tells us to use additional code for the CKD, and that's why we sequenced it next. Then you have J44.9, chronic obstructive pulmonary disease unspecified, followed by Z91.81, history of fall. And you'll see here at the bottom of the slide how we found that superficial injury. You'll go in your alphabetic index, you look for injury, superficial, forearm, and then you see S50.91-. Then you flip over to the tabular listing S50.91, and you'll see that that code requires a 6th character for laterality and a 7th character for encounter timing. So 1 is right, and then initial encounter is the A, and that's how we got the S50.911A code. All right, we have another practice scenario here. You have an 80-year-old male patient admitted for wound care of anterior surface of the right ankle. The etiology of the wound is atherosclerosis. The patient's a former dependent smoker and has atherosclerotic heart disease with angina, type 2 diabetes with neuropathy of the feet. He takes insulin every day for glucose control, and a review of the OASIS C1 states the fat layer is exposed at this wound location. So in this case, you have I-70.233, atherosclerosis of native arteries of the right leg with ulceration of ankle, followed by L97.322, non-pressure chronic ulcer of left ankle with fat layer exposed. Again, there's guidance at L97 category that says code first the underlying condition. That's why, although we're in the home for wound care, atherosclerosis is our primary diagnosis. All right, then I-25.119 is in the third position. That's the atherosclerotic heart disease of native coronary artery with unspecified angina pectoris, or if you're from the Northeast, angina pectoris. We can pick at each other, right, and have a little fun. The fourth position is E11.42, type 2 diabetes mellitus with diabetic polyneuropathy. Then you have your status codes for long-term use of insulin, which is Z79.4, followed by Z87.891, personal history of nicotine dependence. All right, the next scenario, you have a 73-year-old female admitted for wound care of a pressure ulcer of the sacrum. It's noted to be 16 by 15.3 by 3.2 centimeters in size with well-defined edges, and muscle and bone tissue is visible, and there's no non-viable tissue noted. The patient is wheelchair bound with maximum assistance needed to transfer a wheelchair to bed. She is obese and has a BMI of 41 due to excess calories. Patient also has chronic systolic heart failure and hypertension. In this case, from the description of that wound, we already knew it was pressure. The stage is stage 4, so we have L89.154. Then we have I-50.22, chronic systolic congestive heart failure, followed by I-10, essential primary hypertension, followed by E66.01, morbid obesity due to excess calories, followed by Z68.41, BMI 40 to 44.9 adult, and then we have two status codes. Z99.3 is your dependence on wheelchair, followed by Z91.81, history of falls, which is also the same code for risk of falls. Two things, hypertension should be sequenced right after the heart failure code. There's guidance in that category that tells you to code the hypertension after. And then also your E66.01 code tells you to use additional code for the BMI, and so those two have to be sequenced together as well. In this case, you have a 62-year-old male patient is admitted for wound care for a partially dehisced incision of the abdomen following surgical repair of a hernia. He has developed a DVT of the right posterior tibial vein post-surgery and is on warfarin nightly. The patient has COPD and hypertension. So what are we going to code first? We have a complication here. We have a partial dehiscence, and that is T81.31XA, disruption of external operation wound, not elsewhere classified, initial encounter. That's followed by I82.441, acute embolism and thrombosis of right tibial vein. That's followed by J44.9, chronic obstructive pulmonary disease unspecified, followed by I-10, essential or primary hypertension, and then last we have a status code for long-term use of anticoagulants, which is Z79.01. All right, let's get on to our next scenario. In this case, your patient's a 71-year-old with peripheral vascular disease with an ulcer on the lateral mid-left foot. Physician documents dependence on smoking. Patient also has diabetes and takes oral antihyperglycemics and insulin daily. Nursing is needed for wound care and pain control. PT is referred for gait training to increase the distance the patient can walk for ADLs, but a therapist couldn't go see the patient until day 6. Patient is a fall risk. Nursing assessment states the fat layer is showing in the ulcer and that the patient's glucose has been between 200 and 350 the last 2 weeks. A call to the physician is documented with confirmation of hyperglycemia. Couple things we want to talk about. PT's referred in for gait training. but they couldn't go until day 6. Remember, you have 5 days, a 5-day window to gather information from other disciplines and from the physician. If your PT doesn't go out in that 5-day window, you can't use those diagnoses. You can't coordinate that care. So you're going to have to leave that off and just make mention or add a physician's order on day 6 to amend the 485 plan of care and add those diagnoses in, okay? So what we have in this case is I-73.9, peripheral vascular disease unspecified, followed by L97.422, that's the non-pressure chronic ulcer of the left heel and midfoot with fat layer exposed. We said the patient's diabetic, but we don't know what type. There's guidelines and conventions in ICD-10 that says when you don't know the type of diabetes, your default is type 2, even if the patient uses insulin. So you have, in this case, E11.65, type 2 diabetes mellitus with hyperglycemia. Then you have F17.210, nicotine dependence, cigarettes, uncomplicated. Then we have 2 status codes, Z91.81 for the risk of or history of falls, followed by last Z79.4 for your long-term use of insulin. All right, our next scenario, you have a patient referred for home management of cellulitis and weeping of bilateral lower legs due to lymphedema. H&P reports cellulitis is due to group A strep. The patient is severely obese and also has hypertension and chronic obstructive asthma. Patient's having symptoms of depression and has been started on Wellbutrin for this new diagnosis. She will need Pro-4 compression wraps changed 3 times a week with plans for compression stockings to be used long-term after that. The height is 5'6" and weight is 240 pounds. So in this case, you have cellulitis of both legs, and there is no bilateral code, so we're going to code both. Whichever is worse would go first. In this case, we have L03.115 for cellulitis of right lower limb, followed by L03.116 for cellulitis of left lower limb. And we have guidance that tells us to use additional code to identify the organism if known. In this case, we did know, so B95.0 is Streptococcus group A as the cause of disease is classified elsewhere. We have I89.0 lymphedema, not elsewhere classified. F32.9 major depressive disorder, single episode unspecified. We have a height and weight, so we can calculate the BMI, and we had a diagnosis of obesity. So E66.01 is morbid obesity due to excess calories. Z68.38 must go right after that because we have instructions to use additional code for BMI, and that BMI is 38.0 to 38.9 adult. Then we have J44.9 for our chronic obstructive pulmonary disease, and finally I10 essential hypertension. All right, the next scenario, our patient's a 68-year-old male referred for wound care. Your patient is a 68-year-old male referred for wound care. Patient has a stage 3 pressure wound on the left above the knee amputation stump. He had a prosthesis fitted 8 years ago and he never went back for follow-up reevaluation. The wound developed approximately 3 weeks ago and treatment was just changed to hydrogel. He had amputation due to gangrene and osteomyelitis years ago following a motorcycle accident. The patient also has depression and gastroesophageal reflux disease with esophagitis. Patient's a fall risk and PTs needed for transfer and crutch training. The codes in this case, you have L89.893 for pressure ulcer of other site, stage 3. Remember from our first class, other site means you know what the site is, but there is not a code for that particular site. That's other. Unspecified means I don't know where the site is. Okay? So in this case, we know where the site is located, but there is no code that locates that particular site. So in that case, you have L89.893, pressure ulcer of other site, stage 3. Next, we have F32.9, major depressive disorder, single episode unspecified, followed by K21.0, gastroesophageal reflux disorder with esophagitis. Then we have Z89.612 for acquired absence of left leg above the knee. And then we have Z91.81, history of falling. Our next scenario, the patient is referred following a right lower lobe pneumonectomy due to lung cancer. Nursing will need to perform incision assessment and dressing changes 3 times a week. Patient also has a stage 2 pressure ulcer of the left heel, CHF, and is dependent on oxygen. So in this case, we don't have any kind of complication noted. It's just aftercare due to the surgery for neoplasm. So that first code in this case is going to be a Z code. Z48.3, aftercare following surgery for neoplasm. Then we have C34.31, malignant neoplasm, lower lobe, right bronchus or lung. Then we have the pressure ulcer on the left heel, stage 2, that's L89.622, followed by I50.9 for heart failure unspecified, and then Z99.81, dependence on supplemental oxygen. Now, since this is routine aftercare and not a complication, you could also add the dressing change code at the end, the status code for encounter for dressing change. That would be perfectly fine. Okay, our next practice scenario, the patient's referred for wound care on an ulcer that has appeared on the distal foot due to diabetic neuropathic disease. The physician notes the diabetes is type 2 uncontrolled with polyneuropathy. The skilled nurse notes only the skin is broken at the ulcer site. Patient had his left great toe amputated 8 weeks ago due to a diabetic ulcer with gangrene and osteomyelitis. The new wound is proximal to the great toe. He also has coronary artery atherosclerosis and takes insulin daily. In this case, your first code would be E11.621, type 2 diabetes mellitus with foot ulcer. That's followed by L97.521, non-pressure chronic ulcer of other part of left foot limited to breakdown of skin. Then you have E11.42, which is your type 2 diabetes mellitus with diabetic polyneuropathy. Then you have I25.10, atherosclerotic heart disease of native coronary artery without angina. As Z89.412, acquired absence of left great toe. And then Z79.4, long-term use of insulin. Okay, our next scenario, you have a patient admitted for skilled nursing services. He will be on IV antibiotics 3 weeks for MRSA infection following a left total knee replacement, and he's going to need wound care. The incision is currently open between staples, and a call to the surgeon confirms dehiscence. The patient's obese with a BMI of 39, has primary osteoarthritis of the right knee in addition to this poor other knee, right? So in this case, we have a complication. We have an infection. That infection goes first. So your primary diagnosis in this case is T84.54XA, which is infection and inflammatory reaction due to internal left knee prosthesis initial encounter. Then you have B95.62, MRSA infection as the cause of diseases classified elsewhere. Then you have T81.31XA, disruption of external operation, surgical wound, not elsewhere classified. E66.01 is morbid obesity due to excess calories. Z68.39 is BMI, adult, 39.0 to 39.9. M17.11 is unilateral, primary osteoarthritis, right knee. Z45.2, encounter for adjustment and management of the vascular access device. That's going to be your PICC line. Z79.2 is long-term current use of antibiotics. All right, the next scenario. Your patient's referred to home health services for treatment of CHF and drug-induced pemphigus due to enalapril, which the patient was taking as prescribed until yesterday when it was discontinued by the physician. Skilled nurses needed to teach and assess CHF as well as teach on new topical steroid cream, which the caregiver will need to apply twice a day. All right, so your first code would be I50.9, heart failure unspecified. Now we have pemphigus due to the drug enalapril, right? So we have to know how to code that. In this case, you're going to go in your alphabetic index and you look up drug-induced pemphigus. That's L10.5. Now there's guidance that tells you to use additional code for the adverse effect if it's appropriate. So when you do that, you're going to have to use the table of drugs and chemicals to look up adverse effects, poisoning, or underdosing. How do you know the difference? Adverse effects happen when the patient is taking the drug as prescribed and it's prescribed correctly. Poisoning is when they take too much of the drug, and underdosing is when they take too little. So we know the patient was taking the drug properly until it was discontinued yesterday, so that would be an adverse effect. And that code is T46.4X5A. Now, when you look at the chapter block T36 to T50, it tells you to code first the nature of the adverse effect, and that's why the drug-induced pemphigus goes before the adverse effect. So in closing today, we've gone through several wound care scenarios. I do appreciate you being with us and trusting us to help you with learning your ICD-10 coding. Again, I'm Jennifer Gibson here at Axxess, and I'm happy to help you in any way that I can. You can feel free to give me a call on the number that you see here on the slide, or you can email me anytime at jgibson@axxess.com. That's J as in Jennifer, Gibson like the guitar, at axxess.com, and I'm happy to help in any way I can. And by the way, usually it's going to be best to send me an email. I may be in meetings or traveling to speak around the country, but usually I can respond to an email if I'm on a plane or in a break or something with a seminar. So feel free to reach out anytime you have questions. I hope you're looking forward to the next ICD-10 coding webinar that we'll be putting on, and that will be coming soon as well. So have a wonderful day, and thank you again for joining us here at Axxess. And I want to personally thank you for what you do to make sure that our patients who are well deserving of the care that we give are cared for. Okay? Have a great day. Thank you so much. Bye-bye.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at Axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.